Good morning, and thank you for joining us. I'm Maria Tilden, Executive Vice President for Public Policy and Government Affairs here at CareFirst, and I'd like to welcome all of you to today's discussion regarding the future of telehealth. As we all know, the pandemic dramatically accelerated the use of telehealth, which played a vital role in helping individuals access care, preserving critical healthcare resources, and reducing the spread of COVID-19. Many of the temporary telehealth policies made by federal and state policymakers during the public health emergency strengthened access and ensured the continued affordability of telehealth services. Now, policymakers must assess the role of telehealth that is most beneficial for patients moving forward. We joked in the pre-call earlier today that we're assessing, but there's an awful lot of hand wringing. And so this conversation is particularly timely. CareFirst is thrilled to convene this panel of experts to discuss the opportunities for policymakers to sustain telehealth successes moving forward. We hope you find the session enlightening and filled with perspectives to help you inform legislative and regulatory next steps for virtual care. And with that, I am proud and delighted to introduce you to our moderator, CareFirst Vice President for Provider Collaboration and Network Transformation, Brian Wheeler.
Thank you so much, Maria, and good morning, everyone. I am absolutely thrilled to be here today to moderate this important dialogue. For our audience, I just want to let everyone know we do have closed captioning on today's call. So if you'd like, you're welcome to enable closed captioning to help you interpret our discussions today. So the COVID-19, as Maria said, COVID-19 spurred profound changes in healthcare delivery across the United States and around the world, with many providers and clinicians incorporating or expanding telehealth services to provide access and care to patients throughout the pandemic. A Fair Health study of private payer healthcare claims found that telemedicine claims increased by 4,000% higher in March 2020 compared to March 2019, 4,000%. A RAND survey found that between mid-March and early May 2020, telehealth was used by over 40% of patients with a chronic physical health condition and 50% of those with behavioral health conditions. So massive shift in utilization to telehealth, obviously driven by lockdowns and inability to access practices. As many emergency authorizations approach their sunset, state and federal policymakers are now trying to figure out what the right direction is for telehealth from here, and what does a post-pandemic telehealth world look like. Policymakers are grappling with laws and regulations related to provider reimbursement, patient privacy, prescribing, provider licensing, scope of practice and access, especially when we're talking about issues related to the digital divide. To discuss important policy and regulatory considerations regarding the future of telehealth, we have a number of distinguished panel members today. I'd like to introduce you to each one of them. Let me start with Melisa Byrd. Melisa is the Senior Deputy Director and Medicaid Director of the DC Department of Healthcare Finance. As the Principal Manager for the district's Medicaid program, CHIP, Alliance, and Immigrant Children's Programs, Melisa directs the day-to-day organization, planning, implementation, and evaluation of those programs to ensure compliance with federal and district laws. These programs provide health coverage to 40% of the residents of the District of Columbia. In addition, Melisa advises the DC Healthcare Finance Director on all major policy and budget issues related to the programs, to the district's healthcare programs. We're excited to have Melisa share her insights on the role of state-level programs of policy and telehealth. Next, Dr. Ateev Mehrotra is the Associate Professor of Healthcare Policy and Medicine at Harvard Medical School. Dr. Mehrotra's research focuses on the impact of delivery innovations on cost, quality, and access, very relevant for today's discussion. Dr. Mehrotra is the author of a Commonwealth issue brief, Telemedicine, What Should the Post-Pandemic Regulatory and Payment Landscape Look Like? And has testified on Capitol Hill regarding telemedicine policy issues. We're looking forward to hearing more about the report and its regulatory recommendations. Next is Magda Rusinowski. She is the Vice President at the Business Group on Health. Magda actually leads the Cost and Delivery Institute in identifying best practices and promising solutions to employers healthcare cost and delivery challenges, and influences a number of market-based payment and delivery reforms. We're glad to hear more from Magda on the self-insured employer's perspective on telehealth as we move forward. And finally, representing the provider community is Sam Starbuck. Sam is the Vice President of the Privia Quality Network. He leads the implementation and operations of value-based programs and activities supporting over 450,000 patients and 1,200 providers in the DC, Maryland, and Virginia area. Sam, we're looking forward to hearing about your experience at Privia, both during the pandemic and generally your thoughts regarding telehealth and its integration into care delivery. So thank you all so much for being here. It should be a very, very good discussion. So based on a February 2021 health affairs study conducted by Dr. Mehrotra and others, we found that during the pandemic, 30% of all visits were found to be provided via telehealth. And the weekly number of telehealth visits increased 23-fold compared with the pre-pandemic period. Dr. Mehrotra, can you discuss your perspective on the successes of telehealth enabling access to care during the pandemic? I would love to hear your thoughts and your perspective.
I think that it's been clear to me, and as well as I think just clinicians and patients around the country, that really telemedicine has been a lifeline for patients in terms of getting care from their providers. And you focused on the telehealth visits, but there's been a lot of other ways that people have been interacting, huge increases in portal messages and other mechanisms of e-consults. Every form of telehealth has really expanded quite rapidly during the pandemic. And in some research we've done, as research of others have done, one of the things is way back early in the pandemic, I was so worried that our patients with chronic illnesses, because they weren't able to access care, would have a real negative impact on their health, for example, for diabetes care. And one of the things is that we see is, and I think partially due to telehealth, that in many cases, medication use, some preventive care services, we're actually being able to maintain those through the pandemic. And so I think that's really been important. One place where I think we haven't seen where I'm a bit worried that we're going to see a negative impact is we did a good job of, and we, as I'm saying, the medical community, of helping those patients with chronic illness they were already plugged in. I'm worried a bit about the identification of new patients, of new problems, new diagnoses. I think that's where we really, where I think the research is going to have to focus on to see if we see that negative impact.
Right, and just to follow on, I noticed in your health affairs piece, you really delved into telemedicine access and income level. Would you care to comment on your findings related to folks with economic challenges being able to access care during the pandemic using telehealth?
No, I think this is Brian, this has been an enormous concern for everybody, clinical community, policymakers, everyone else, is that while we're so excited that telemedicine's ability to improve access to care, we're obviously concerned that we already have such profound disparities of care in terms of access to care in the United States, and that telemedicine, its increased use, will exacerbate those disparities because some of our disadvantaged populations may not be able to access the care as well as other groups. And so there's been a lot of interest in looking at the disparities in telemedicine use during the pandemic. Some of the results are a little bit surprising. We do see some differences by income. Interestingly, in some recent work that we've been doing outside that piece, we haven't seen the differences that I was worried about by race and ethnicity. Actually, those levels have been pretty similar in terms of telemedicine use, which is great. The one area that we've seen a huge disparity is in between urban and rural residents, where rural residents are much less likely to have a telemedicine visit than urban residents. And I think that's the key area, because we already know that our rural communities there was an enormous disparity both in access as well as quality.
Thank you, appreciate that.
Yeah,
Sam.
I would add on to that from the provider perspective. We saw that play out, in real life. In looking at the data for the number of visits done over the last 12 to 18 months, we did not see a disparity between, race, ethnicity, gender, but where you really start to look at it is, and our medical group spans DC, Maryland, and Virginia. So the further away you get from the DC metro area, the less telehealth utilization you see, especially as you get down to the southwest, corner of the state of Virginia, where even in the height of the pandemic, the number of virtual visits being done were still minimal. There's no broadband, there's no ability to access those services down there. And the best example I have is I have a physician leader, a regional medical director who lives on a farm outside of Lynchburg, and he still can't access internet on his farm. So, we're doing phone calls with him, and he can't see the screen and do any of that in the midst of the pandemic. So I think that is certainly still a relevant issue. And we saw that rural versus urban divide play out, quite often.
And I would say for the district's Medicaid program, so we serve primarily folks that are low income or about 200% of the poverty level and lower. And our telehealth or telemedicine utilization is not, doesn't stray too far from, I think, some of the work that Dr. Ateev has shown in his research. We had probably 1 to 0.2% utilization of telemedicine that January, February, and then we jumped up to between about March through September of 2020, seeing about 20% of our outpatient visits through telemedicine. And so certainly seeing a huge increase like everyone else, and that touched on about 37% of our beneficiaries. So folks were certainly able to access it. And back, Brian, to your earlier question about the flexibilities allowed through telemedicine in the pandemic. From a Medicaid perspective, I really see our role as the Medicaid agency is twofold. One, we need to ensure that individuals have access to care throughout the pandemic. But the second kind of main role and responsibility is also ensuring that we have a viable healthcare system or a viable provider network. And I do think in the short term and in the long term, so once we come out of the pandemic too. So the flexibility provided through telemedicine, I think allows our providers to maintain some stability throughout this pandemic and quite frankly, an income and that viability so that, we're not going to flip a switch and tomorrow everything's going to go back to normal. But as we ramp back up, I do think that flexibility and allowing folks to still be able to interact with their patients in one way or another through telemedicine has, helped enforce and kind of stabilize our provider network and our health care system at large so that as we do come out of the pandemic, we have, folks in place that can continue to serve our beneficiaries in the Medicaid program and across the district.
Absolutely agree, Melissa. Very, very good point. Well made.
Magda,
yeah. Sorry.
Go ahead.
I was just going to say, what do you think the role of payers, providers, and government is, thinking from the employer's perspective, in making sure that the infrastructure is in place to enable telemedicine? How do you think about that when you think about your employer group members?
So I don't know if this is just related to the broadband access, although this is a very big issue. Right? Adoption of the telemedicine and telehealth spurred by the pandemic has had many reasons, and I think it was increased comfort of using telehealth services by patients, but it was also increased comfort of the providers. So the gaps that you all spoken to and the RAND study that was published that really illustrates really clearly, I'm not sure if we can blame it all just on the broadband. I think and I think broadband will be fixed maybe or hopefully by investments in the infrastructure. Because it impacts not only ability to use health and access virtual health, it also impacts the ability we work, the ability we study, etc. So I hope as a broader issue of broadband is addressed, that also helps adoption of telehealth. But if we look specifically at telehealth as to what might have generated those barriers and what the solutions might be, we may look at the underlying reasons. Why is adoption lower in rural and lower income communities? We have to look at things like language barriers, computer literacy. All those are connected to utilization of telehealth. If somebody does not have a good English proficiency, they're going to be feeling more comfortable seeing the provider in person. The providers that might be serving those communities might be less able to invest in the infrastructure that's required to actually provide telehealth visits. So it's going to be a long process to close those gaps. We know that telemedicine is not just putting a phone in front of a doctor and a patient. It requires a broader investment, and that investment has to be focused on and informed by why those gaps exist in telehealth adoption in certain communities.
Magda, I think those are great points. I would add on, one of the surprises for us once we saw that increased utilization of telemedicine and some of the barriers got down to the level of individuals and what data plans they have. And so, and that's where audio only really came into for us in the district. Of folks might try to connect and they don't have the data plan to support that, and or they need to use those resources for other things, for whether it's for schooling or so forth. And so for us, that was something that was a bit eye-opening that we hadn't thought about. We were thinking more, bigger picture of broadband and access in those terms, but we have certainly learned throughout the past several months that that's another level of consideration in terms of people's ability and capability of accessing telemedicine.
Mm-hmm.
Melisa, that's a great tee up to the next question, actually, that I wanted to ask. Some of the policy changes that were made, for a long time, an in-person visit was required to have a billable encounter, right? And then the pandemic caused some payers did cover video visits in the past, and now we've got audio only. But, there's a whole bunch of things that were done to enable access during the pandemic. As the policymaker in the district, how do you think about the policy changes that should be permanent and what should lapse, and how we should make those decisions? What do you think about that?
Great question. It's certainly something that's front of mind as we go through each month of the pandemic and hopefully coming towards the end of the pandemic. In the district, for district Medicaid, we certainly see telemedicine as a modality of service. We think that provides a great level of flexibility that is supportive for both the provider and the folks that we serve. It would be really, I think in all things healthcare, it's like, it'd be great to have consistency across payers, but that is always challenging. It would be also great to really have a defined standard of care. So from our perspective, it's a modality of care. So long as, you can deliver the same standard of care, whether it's in office or through telemedicine, that's sufficient for us. But, folks may have varying opinions of standard of care. And then other things that really are front of mind that we will be thinking of and, would like to see further guidance on, whether it's from the federal government, other places, certainly on documentation, so you can support the telemedicine service, so that it is meeting that standard of care. And then also just one of the things certainly is on consent strategies. So how do you know that the individual you're working with has consent to the telemedicine, consent to sharing information, and so forth. So those are the things that we're definitely looking out in the future. And for the district specifically for Medicaid, we were fortunate that we had telemedicine. It was we were ready to go. We had rulemaking, all the kind of like regulatory pieces you need. We weren't starting from scratch, which was great. And we made a couple really quick early changes. One, allowing home as originating site, which wasn't allowable prior to the pandemic, and then allowing audio only, that also was not allowable prior to the pandemic. And these are components that I anticipate will continue on. And I think one of the really great things here with telemedicine is it is really helping us meet our beneficiaries where they are and how they want to get care, and just adds kind of another tool in the toolbox for doing so. Thanks,
Melisa. Ateev, based on your research, what do you think the driver should be to making those policy decisions going forward on things like what types of things are appropriate to be covered by telemedicine, the audio only versus video? How would your research inform policymakers going forward?
Brian, I think the central issue here is that, and why Maria referred to this as the hand wringing, is we're in this really awkward balancing act. Well, we all recognize the tremendous ability to improve access to care that telemedicine provides, and the potential to improve specialty care, chronic illness care, preventive care, and meet a lot of people. But I think now we should bring also the other side of this. Why is there any worries then? Let's just open up the floodgates. And the real issue is the concern that the very benefit is all of the very strength of telemedicine, its ability to prove access, also could be its Achilles heel, which is that by making care so convenient, utilization will go through the roof and there will have an increase in spending. Whether that's true or not is something we can debate. There has been very limited research on that. I can comment on some of the work that we have done. And so that's the balancing act of how do you maintain that? And so how do you decide the good stuff versus the bad stuff? People use the word value in that circumstance. And they'll say, well, I have said that we should try to focus our energies on high value applications where we think that telemedicine will improve outcomes for patients at a reasonable cost and not be used for low value services. What does that really mean concretely? I know those are all like, it's nice to say value. What does that actually look like? I'll just give you some examples. If you take a patient with diabetes who, it's pain in the tuchus to get to the doctor's office, they can't get there, their hemoglobin A1C levels are above 10, and you can use telemedicine to reduce her hemoglobin glucose control because she can have more access, adjust her insulin. That's a very, very high value application of telemedicine. What are low value applications? People have raised, everything's good. We'll just do another quick follow-up appointment. Or let's discuss your laboratory results via telemedicine. Or, it's so gosh darn convenient. Let me just make sure everything is okay for my cold. Those are all applications which make a lot of sense. There's nothing, malicious about it, but in net could tremendously increase utilization and increase spending. So that's the key thing that I think as we think about the policies, how do we encourage high value and discourage the low value care? And I'm happy to jump into some examples if we get into that later.
So from the employer perspective, utilization, and we have been watching utilization, our members have been watching utilization. One thing important to note that at this stage, still telehealth, with all of those increases in utilization that you have talked about, has not closed the gap created by the care that was avoided or deferred. I think while everybody worries initially about low value visits and overutilization, I think we're still far from studying that because right now everybody still feels like we desperately need telehealth to keep helping us continue to close the gaps. And in terms of assessing value, there is this school of thought that really assessing the value of telehealth is no different than assessing the value of in-person visits. It's the same medicine, just delivered virtually, and it should be the same. But there's significant, I think, investments that might be required in generating value digitally, right? So what's foregone through skipping the in-person visit can be made up for virtually, and some specialties are better suited for that than others, mental health being a prime example. If both providers and in some cases employers make an investment in some of the tools that might be required to deliver care, and make investments in data that might be available to providers, make investments in patient portals, etc. So I think I'm transitioning us to possibly the value discussion, but utilization is great. It's a great concern, and it's built a backbone for us to build further on quality of care.
Yeah. And I apologize, Magda, if I just jump in. I fully agree with you that during the pandemic, telemedicine has been critically important. There has been no substantive increase in utilization. And so then the real question is, does that mean that won't happen after the pandemic? Because we all recognize that the American public, understandably, has been a bit nervous about getting care. Maybe that's changing now in the last month or two, but till now they've been very nervous. And so the real question is post-pandemic, what's going to happen? And you see a lot of policy conversation from MedPAC recommendations to a number of states that have implemented 1 to 2 year trial periods post the pandemic so that we can get a real sense of what's this utilization question. Is it going to be a problem, or maybe it's not going to be a problem? And I think that's why there's so much policy interest in those trial periods.
So Sam, I'm interested in the physician's perspective. I'm sure you have had hours and hours of discussions with the physicians in your group over the past year before the pandemic, and then as things ramped up during the pandemic, about the clinical appropriateness and how they feel about their ability to treat patients and the outcomes they think they're generating, the appropriateness of different use cases for telemedicine, audio only versus audio plus video versus in person. Can you tell us what your docs are thinking and how they're viewing this and what they might recommend to policymakers as we move forward?
Yeah, absolutely. The one way, if I were to sum it up into, a quick, punchy line, it is, I think there's an important differentiation between virtually integrated versus virtually only, or virtual only. And when I say that, I mean, our approach and the approach of our physicians is this virtual visit capability, or the ability to deliver telemedicine to their patients, is now just another tool in their tool belt and a way for them to provide care for their patients and enable access and through a new means. It's not, and I think where a lot of the worry comes going forward is, if we return to a sense of normalcy, are we going to be converting and doing a lot more of these virtual type appointments that are more convenient on top of everything else that aren't necessarily necessary and needed. But it's important to, at least our approach and what our physicians are viewing it as is, Ateev, your example of the diabetic patient is one that our providers quote all the time. I have a diabetic patient who's a construction worker, and leaving the construction site on their 30-minute lunch break is not possible. But now I can do a virtual visit with them while they're sitting there at work during their lunch break, and I've got their A1Cs under control. And things like that, where you are enabling the continuum of care and allowing providers to seamlessly connect to their patients when, where, and how those patients want to receive their care, is what's going to, in the value conversation, create that value, but it also, from a provider perspective, enable that use case and that appropriate use of the virtual environment and telehealth technology to be sustainable. Because one thing that's often overlooked from the provider side is that providers are not necessarily quick to adopt to change, right? They've got their workflows and their practices, and it's hard to get them to change that. Well, the pandemic, was obviously a forcing mechanism to change, but now the question remains, how many of those providers are going to maintain that change and, the adoption and utilization of that technology as it goes forward? And I think if it's not integrated into their workflow and integrated into their day-to-day, then, I don't know that we're necessarily going to see the continued utilization at the clip that it is. But if we are conscious in our policy making and creation and policy decision making, that there is a difference between a virtual only environment, right, where I'm operating 100% in the virtual world, versus a virtually integrated environment where I still have my brick and mortar practice. I'm still seeing patients in my office every single day, but I'm seeing 2 patients, and then I pop in and I do a virtual visit to accommodate that patient and maintain that continuity of care. But then I'm back into seeing more patients virtually. Being conscious of those differences and the delivery of care using telehealth are critically important, are something that's top of mind to our providers who are mainly primary care physicians. They don't want to be lumped into that same bucket as the what are commonly referred to as the doc in a box sort of environment where it's a virtual only, but instead this is an integrated experience that we deliver to our patients to ensure that connectivity and continuum of care is maintained.
An extension of the practice. And related to what you just said, and also sort of teeing up the next topic for the panel, this shift to telemedicine, telehealth, spurred by the pandemic, is occurring at a time when the market is moving toward value, away from a volume-based healthcare system to a system that rewards and pays for value. The folks at CMS and CMMI and folks like Melisa are moving payers in that direction. Commercial payers and employer groups represented by Magda are also moving and pushing in that direction. So how do you think about, and I'll start with Sam, since you were just talking about the impact on practices, and then we'll go around. I'd like to hear everyone's perspective on this. How do you think about telehealth as a feature of, how does it fit into the move to value as we proceed? How might we think about it differently? And then, so we'll start, Sam, with the physician perspective, and then go around the group here and get the rest of the perspectives as well.
Yeah, I'm going to bring that specific patient example back up of that diabetic patient, because almost a third of people in the United States have diabetes. It's almost one of our biggest challenges that we face from within our medical group. When you start talking about value, like managing the diabetic population is a big component of that. And, without virtual health and without telehealth, you're hamstrung to getting those patients back into your office. And of course, I'm talking about this transition period, right? If we're talking full risk and full value, then all of these hurdles of getting paid go away. We're in an environment where we have the premium dollar and we can do whatever we want. But we're talking in this transition phase where we all have our foot in the proverbial two canoes, and we're trying to figure out how we keep our practice open, but also win in that environment. And I think this capability now it enables providers, it gives them a new tool to meet patients where they are. And that example of that diabetic who has chronically been uncontrolled not because they want to be, but because it's all the hurdles that are in place for them to come into the office, it now removes those. And it doesn't remove all barriers. There's still, the change management that has to occur, behavior change and those sorts of things. But the likelihood of that occurring with more frequent touch points to their provider and their PCP to keep them motivated and on track, monitor, and adjust insulin titration and those sorts of things are going to yield better results. So from a value perspective, having that greater connectivity for appropriate use cases integrated into the, experience and extension of the primary care provider, I think is a win-win, and is something that we believe wholly in. And tying this back to some things touched on previously, I think the removal of that originating site requirement and allowing folks to be able to receive care in their home and not be at another physician office, I think that's critical. It's almost like saying we're going to give you this new technology, but you still have to go to the doctor to receive it. Okay, well, it's not necessarily that useful then, but being able to receive it and access these telehealth visits wherever they're at are important. So I think in the transition to value, critically important, improving patient satisfaction, provider satisfaction, and obviously impacting outcomes and quality as well. So we're checking all the boxes on the quadruple aim there.
I think it's no secret that telehealth and fee-for-service model don't work well together. I think there's a reason why those providers who are in value-based arrangements or providers like Kaiser, even before the pandemic, were more successful in actually putting virtual care delivery successfully into or building it into the integrated care delivery. And Sam, you used the word integration so many times because value is generated by integrated health. And integrated health and fee-for-service also don't match well. So yes, we are in this extremely difficult and extremely interesting transition period of not only how we pay for telehealth, but how we actually pay for continuous integrated healthcare delivery. And we spoke a lot with our partners about integration of behavioral health into primary care. And in primary care has different considerations for integration value, and virtual first primary care is a new concept that holds a lot of promise. And there are also differences in perception of value between virtual first and virtual only primary care. And then there's all the other specialties, right? So in the perception of value by the purchaser of services, I think patients will see themselves as purchasers because they have some sort of out-of-pocket exposures, and employers will see themselves as purchasers. And value perception by patient is going to be different than that from employer. Employers are going to look for value generation through telehealth through the lens of total cost of care, and appropriate measurements and integration of virtual care delivery and virtual care solutions into total patient experience. Patients are going to have some barriers, I think, in paying, and we talked about it previously, in paying the same amount of copay or coinsurance for virtual care visits, as their perception of value for a virtual encounter is going to be maybe lower or maybe less so than they would see the value of in-person visits and going and seeing all the nurses running. They're not going to see all the infrastructure that actually supports this virtual care visit that they can see. So I think employers are going to have some questions to answer once the policy side is sorted out on the plan design and programmatic design solution side in terms of how they present it to the patients as well.
I think I just want to touch upon a couple of those points that were raised. First, I want to really emphasize what a critical point that Magda raised is we are hearing patients who are kind of really, really annoyed. You want me to pay $100 for that 5-minute phone call? And, you know, and it's a perception of value, but it's a major issue when we think about from the payer perspective, how does benefit design track with there? And you can understand where they're coming from because previously they got it for free. And so I think that's one major issue. I also wanted to, Sam raised this issue previously, and I think it does tie into your question, Brian, about value-based payment, which is the two camps, if we were to put that in. And I think from policymakers' perspective, I think overly focused on the good guys, if you want to put it that way, the existing primary care providers, the existing clinicians who live in the community who are now adding telemedicine as a second option for them. And then there's the other camp, which I don't think is getting enough attention, but where telemedicine was growing much more rapidly prior to the pandemic, which is the hundreds and hundreds of different companies that are virtual only, that have seen from virtual, we talked about urgent care, but you name the condition from menopause to mental health treatment, opioid use disorder, and a number of companies that are virtual endocrinology providers. And so the tension, I think, is what do you do about them? You see that the Congress in the December Act, when they instituted expansion of telemedicine for mental health disorders, put a clause in that you have to have an in-person visit before telemedicine. I think the policy rationale for that is that they want to, quote, focus on the good guys and worried about the explosive growth. Now, I've used very provocative terms of good guys versus bad guys, but I think we have to recognize that these telemedicine only companies are playing an enormous role and can be very beneficial to the American public. For example, we've been doing some work on telemedicine for opioid use disorder. These companies play a huge role, very valuable, increasing access to care. And do we really want to put in policies that are going to shut off employees or beneficiary access to those companies is really critical. And then the last point, and the reason I thought of it really tied in with value-based payment, was if you pay Sam's group a capitated payment of, I don't know, $100 per member per month or 50, whatever the number is going to be. So you take care of patients, and then one of their patients says, well, I want to go to that tele-OUD or tele-endocrinology company. You really prevent them from doing so? That creates an enormous tension because that patient could gain value, but you're, as the payer, you're saying, I'm already paying Sam's group to do this. Why should I pay extra for this additional care? And so I think this is going to be an enormous thing for us to think about. And these companies are going to grow very, very rapidly.
And they have been growing branches really quickly because, I have the reaction to, and I know if you don't mean to label them as the bad guys, but those innovators actually created the backbone of telehealth delivery that enabled us to some extent, right? The infrastructure existed and employers were investing in that infrastructure of telehealth solutions providing chronic condition management, telehealth solution providing mental health, etc. And those have seen the utilization and rapid adoption. MSK solutions, probably the highest growth in MSK services was through virtual MSK services that employers have adopted. So they have built this foundation, and now they will struggle to figure out how to interact with the rest of the system going virtual. And it's going to be very, very interesting to watch. But they have played and they have done an enormous service to healthcare by actually creating this infrastructure.
Healthcare is a sector not accustomed to being disrupted, and here we see some disruptors coming in. Melisa, please go ahead.
Oh, sure. I was just going to say, I would think a lot of what we've seen kind of grow up on the side that you're speaking to is in part because there obviously was a demand, and I would argue probably in part on convenience of the user, right? It's really easy to access. And so for me, this kind of resonates to some of what Sam was saying earlier. I mean, it is, in the work that we've done in kind of like practice transformation and doing a lot more, we've done a lot more as a Medicaid agency over the past 2 to 4 years, a lot more investment in working on specific provider level technical assistance to help you transform your practice. How do you change your process workflows and whatnot? I mean, it is a huge lift, I think, from a individual provider group to make that change. So, and then, you layer on top, if you don't have the payment mechanisms to support those changes, how are providers going to make that kind of transition as well to meet the convenience factor? So I think there's a lot of, moving pieces, and throughout the pandemic with the rise of telemedicine, like how quickly can we as payers can, kind of the more traditional provider or healthcare system, make those changes so we can provide the convenience, but providing the convenience has got to be convenient for the provider and the beneficiary, right? So back to, is it the $100 per member per month or something else, so that the provider sees why, right now I do my 15 minutes, I submit my claim, I get my payment. And, as a payer, am I providing information back to that provider of how well he or she is, he or she's patient panel is? Are you seeing progress? Are you seeing those outcomes? What am I paying for? So I think, some of it, the convenience factor, it's also to the challenge of trying to actually change your practice and your workflows or process flows, and so that you can meet that convenience that folks are looking for as well.
Melissa, your agency has a very robust plan to move with your health plan partners to a value construct in the coming years. How does telehealth, in your vision, fit into that plan, and how will providers and payers work together, incorporating telehealth to get better results for beneficiaries in the district?
Sure. Well, first, as I said earlier, we see telemedicine as just another tool in the toolbox. Our experience with we have a health homes program called My Health Homes GPS, where it's largely focused on individuals with 3 or more chronic diseases, and really layers in some intensive care coordination. And the feedback we receive from providers in that model is that, in person was not always the best way to reach folks and to access folks and to meet them where they are. They saw that it was much better, one, just to have the flexibility and the option to choose how best to meet that patient's needs, but really that kind of, telemedicine component was really important to drop in. I think the example of the diabetes case is so relevant, to drop in and see at that moment what's going on and make a course correction or provide the kind of support that individual needs at that moment. And you start to see those outcomes. So, going forward, I think telemedicine is an excellent tool. I think, the more that we can build as a payer our data analytics capacity, our information sharing capacity, we want to see the outcome like everyone, and that value for the dollar versus let's get another, let's pay for another claim. Person comes in again a year from now, your diabetes is still unmanaged, good to see you, and moving forward. So I think we'll see this ongoing. And I think, again, it's really just trying to see, it's not a one size fits all. It's really, looking at all the different tools we have to assist in accessing and reaching our patients.
Great. So thank you very much, Melissa. What Magda was mentioning about the disruptors in healthcare, we are getting a couple of questions in from the audience, and one of them was related to that. What about the potential that these disruptors could, disrupt the relationship between a physician and their patient? How do we think about that from a policy perspective? That we've got, folks who have a continuity of care with a particular member in an integrated or mostly integrated system, and then the patient's also seeking care from one of those other providers that you mentioned. How do we think about that from your perspective, Ateev?
So we think about it. I don't know if I have a great solution. I mean, it's a critical issue, right? Because, if a patient, it's, the more cooks around the pot, you're going to have, what do patients tell me? They're kind of annoyed that, do you guys ever talk to each other? Because my endocrinologist is telling me one thing and my primary care, and now you have other people around that, who are also providing advice. On the other hand, to build on what Magda said, some of these providers can do a very good job and maybe I think a better job of managing a particular condition from mental illness to diabetes to other conditions, because they have the resources, the continuous glucose monitor, they have these great apps and so forth. So how do we balance that is going to be very, very critical. And I also want to, and build out, I'd love to get what Magda thinks about this, is that the payers are getting cut out. What do a lot of these telemedicine only companies do? They'll go to employers directly, say, pay us a capitated amount for the number of people you have as employees. And those dollars are flowing directly from the employer to that provider, completely outside of the payer. Sometimes it's going through the payer and sometimes it's not. And so that's another interesting tension, because CareFirst or any other payer can have all sorts of programs and so forth. But if those companies are getting the dollars on the side, then that's going to cause another tension there. So it's an interesting, I don't have a great solution, at least to acknowledge that it is a major issue.
And direct to consumer as well. We see the TV ads, call and we'll have a consultation and we'll get your prescription to you, right? That's outside of the employer and outside of.
And it's a really good point. And you see that all the time on every place you look, from social media to the TV.
Mm-hmm. But ultimately, the employer is the payer, right? In the self-insured world, the employer pays for the claims for the providers. The health plan is really just administering those claims and takes fees for their services, but not for the claims themselves. So employers did make a choice of paying those companies directly, engaging with them directly. And it wasn't the issue of dollars as much as, visibility of data, visibility of impact of those solutions. And they would love to have both, right? They would love to have involvement of health plans and involvement of these solutions, but in some sort of integrated way that data actually enables provider, brick and mortar or telehealth providers who are part of the network to see whatever it is that's being done with that patient or programs that the patient is engaging in. And it's very hard for employers to make that happen, because integrating this data is one thing and they can see it for themselves, but it's very difficult to show it at the moment of need to a patient or to the provider serving that patient. But technology has amazed us recently, and there's so much that can be done with integrated technology platforms. And it also brings us to the idea of patient health record and visibility of that record to the patient, and then carrying it around with them as they access healthcare in various points. So lots of work to be done there as well. I think a lot will be done this year in rethinking what I call the programmatic infrastructure, the relationship that exists between health plans and those point solutions, and how they integrate it for the benefit of the patient and for the care delivery.
Great. So the next topic, and this one will bring us home today and conclude our panel. We've got, we touched on it a little bit at the beginning. I think it's good to maybe finish up delving into it. We've got a patchwork of state regulations and requirements related to licensure, related to coverage. And I think, Melisa, you said earlier, it's really helpful when things are more consistent. We talked about DC, Maryland, and Virginia, and different licensure and other requirements there. What is the right way for policymakers to think about evening some of this out to improve access across time? And as we think about the policy implications of decisions we're making here, maybe if I start with Melisa and then Ateev and then Magda and Sam, we can finish it up today. So Melisa, what are your thoughts about that? You're operating obviously in an area where you've got a lot of porous borders and folks who are living and working across the district and state or Commonwealth lines.
Sure, and I'm sure folks appreciate a Medicaid director talking about consistency when there is often little consistency across Medicaid programs. I don't know that I have a great answer on this one, Brian. We'd like to see more consistency, but then with that, it's like you want to see flexibility too. But I do think, the thing that kind of always is in front of my mind, and this won't answer your question directly, but that, I know that Medicaid is one payer. And so we have our prior authorization processes, we have our telemedicine policies and so forth. And Sam is one provider group, and he's not he's dealing probably with you too at Care First, and you guys have your own set. And so, it's almost, I'm sure it's overwhelming to providers, but to think of like, then when you want to make change or you want to have that consistency, there are a lot of different folks to line up to make that happen. And that just gets complex. So the best thing I can say is, like, from my perspective, is to be mindful of it. And then where are those places where we can have some consistent regulatory action that at minimum sets a baseline and how we approach it as a community or as a health system. So I don't know how well that answers your question, but I think it's, if I had an answer, a lot of folks would be knocking on my door right now.
That's great, Melisa. Ateev, how can we streamline and not have the patchwork?
I think I'm first going to mostly be on this page of just emphasizing the importance of this issue, which is that for a given provider group, as soon as telemedicine plays a role, and if you play a substantial role in telemedicine, the issues of regulations and payment, it's not a minor issue. It is a tremendous issue because you have to deal with many states, all those different health plans, and all the rules, not just for video visits, but audio visits, but remote patient monitoring, e-visits, e-consults. How are you going to navigate all those? And if they're not at all somewhat in congruent, you're going to see a lot of providers do, which is very reasonable, is just throw up their hands and say, forget this, I'm just going to go back to in-person visits. And it's hard if I'm talking to the state director or a state legislator in a state to think, no, you can't Tennessee, you can't think about Tennessee. You have to think about all the states around you and make sure you're aligned. That's not the way that people are focused. They're very much focused on their community, but that's what has to happen. And that is, I just want to emphasize, has been such a deterrence to the growth of telemedicine previously. It was this complex labyrinth of regulations and payment policy. And so
Sam, I imagine that
emphasizing the point.
Yeah, Sam, I imagine that comports with your experience. If you'd tell us previous perspective on that, then we'll go to Magda for the employer's perspective and wrap.
Yeah, I was sitting here reflecting back on the early days of the pandemic, and I recall a Excel spreadsheet that was over 100 lines long, where we were tracking every single payer's various changing policies on a day-to-day basis. And now they cover this, but they don't cover that. And then we had a new communication going out to our physicians, and so yeah, that was a big deterrent. And obviously, I think everyone eventually in the pandemic kind of settled in the same place. And we're now at a point of somewhat equilibrium across the payer landscape. And the question remains, what's going to happen going forward? And, if we go back to that place before, I think there are going to be a lot of providers that are going to throw up their hands. And that is the biggest challenge, because we have to remember that a provider sees a patient, they don't see a payer. And so, if we start to have dramatically different policies and regulations around telehealth coverage, by payer, and a provider is seeing multiple payer types in their practice, it's just going to be very unwieldy, especially if they don't, have a partner to kind of help them navigate that. So, I would reiterate everything that some of the things that some folks have said. I think one thing that seems to be pretty consistent across all is the originating site, definition. I reiterate that. I said that earlier, and something that could be streamlined across, all constituents, providers, and patients, and allowing them to be able to receive those visits wherever they're at. But it is an issue, and it's something that has to continue to be discussed. And it's going to be fun working through it.
So Magda, your members are funding this, and it is healthcare for your members is no small part of their budget on an annual basis. How do you all think about this going forward? And also, you hold us as payers accountable for being good fiduciaries of your healthcare spending. So, what's the right formula from your perspective?
Well, do the easy things first. So employers often count on innovation for reducing healthcare costs. So if policy and legislation at the state or federal level gets in the way of innovation, that something is wrong. appropriate level of regulation is important, but I think this is an area that requires a lot of focus. The low-hanging fruit is state licensing for providers. So employers have the cover of ERISA, and they typically design their programs at the national level, and they often do not have to follow the state rules. But if their providers that are serving the patients are limited in what they can do and how effectively they can do it because of the state laws, that very quickly becomes an issue for employers. So I don't think we have an answer other than increasing the understanding and advocating on behalf of employers and payers to make some of these rules user-friendly for providers, so that innovation can move us forward.
Great, thank you, and thanks to all of you. It has really been an honor to spend time with you today to moderate this group, to exchange ideas and perspectives. Really great representation from different areas, and you all represented your different perspectives very, very effectively. I'd also like to thank everybody who registered for this event today and who's attended, and hopefully you got something really good out of this today that helps inform your thinking going forward. As we collectively face the challenges ahead, CareFirst is committed to transforming the healthcare system to one that is rooted in delivering value and healthier outcomes for all. We want to wish you a great day, and thank you again so much for joining us. Take care all.